is an associate professor here at Kent State University College of Podiatric Medicine in our Division of Surgery and Biomechanics. He obtained his undergraduate degree, his bachelor's degree from Juniata College in Pennsylvania, and then pursued his DPM degree here at the College of Podiatric Medicine, which was then called the Ohio College of Podiatric Medicine, earning his degree in 2011. Following that, he participated in residency training at St. Vincent Charity Medical Center, which is located here in Cleveland, Ohio. Dr. Ehredt is board certified by the American Board of Foot and Ankle Surgery in both foot reconstructive rear foot and ankle surgery, and your interests lie in rear foot and ankle surgery, sports medicine, limb salvage, and research. Additionally, Dr. Ehredt is a commissioned officer in the United States Army Reserve and currently holds the rank of lieutenant. So we're so excited to have Dr. Ehredt here. We're very excited because Dr. Ehredt is one of our favorite faculty members, but he always has the greatest case studies, the greatest pictures that we like to share. So without further ado, I will turn it over to you, Dr. Ehredt, if you don't mind sharing some of that with us today.
Thank you, Carla. Can everybody hear me?
Yes.
Okay, good. Only one minor correction to the introduction. I'm actually a Navy reservist, not an Army reservist.
I apologize. Thank you.
Okay. So I was tasked today to essentially present a case to what I assume are some prospective students, maybe some people that are already coming in, or undergraduate students that are interested in the profession. And so I chose kind of an interesting case here. That highlights, in my opinion, where the 21st century foot and ankle surgeon is going, or really is living currently and working. And that's, in a, kind of a high risk limb salvage hospital-based environment. And so I'm going to share my screen. Hopefully you guys can see this. There you go. Can you guys see that?
Yes, we can.
Yes. Okay. The case is, fairly extensive, but I've kind of simplified it a little bit in order to fit the time period of 30 minutes, is also to fit the, the level of interest in education. Right now you guys have a background in, pre-medical sciences, I'm assuming. But not the specifics of foot and ankle surgery and limb salvage and medicine and all that kind of stuff. So with that said, I do need to thank a couple of people to helping me put this together. So in medicine, right, especially in the residency training environment, we do a lot of cases together, and residents, they work, hand to hand with us in the operating room and in the hospital. And many times, they present these cases as well for, either their own education at, radiology conferences or M&M conferences, that kind of thing. But sometimes they also present them at conferences for competition. And this guy's case actually was presented once by Dr. Paris Payton. You can see her there. And this is the only picture I have of us. It was a screen grab of a video we took for the pandemic. I think actually the school's social media posted it at some point, but in the early pandemic, we gave some sort of little, video, and it's the only picture I have of her and I. So that's a screen grab from that. But she actually won this particular case at a podiatry conference. Residents were competing. So I have to thank her for initially putting it together, but then also most recently, Dr. Darji, who has submitted to a cardiovascular symposium, and she hasn't presented it yet, but she's put it together, and I think she's got a real good chance of winning the competition. And that's kind of the angle that I'm taking here today, is showing how we interact and we're integrated in with the mainstream hospital and all the other surgical subspecialties and medical subspecialties, because diabetes, limb salvage, and all that, quite frankly, is it's a multidisciplinary issue, right? So you have to have a team-based approach when treating these. You can't just, live it under a silo and try to take these cases on, because these patients are systemically sick and they need other things addressed. And sometimes other things happen along the way. you need to know how to communicate with them and know how to discuss with them. And so this is an interesting case that highlights that. So this is a 78-year-old male who has past medical history of diabetes, cataracts, glaucoma, has hypertension as well, and may have had some underlying heart issues in the remote past. But presented to our clinic with what's known as Charcot neuroarthropathy, and what we call Charcot foot, and a wound, right? His chief complaint is chronic wound. And I'm going to put my little laser thing up so you can see that. And you can see this doesn't look super significant, but this has been there for over 2 years. It's chronically draining, and it doesn't really hurt him because he has neuropathy, but it's just obviously affecting his quality of life. He's got to do dressing changes all the time. He lives in a wheelchair for the most part, and has seen a previous surgeon at another hospital who stated that at this point he should have a below the knee amputation. There's not much that can be done. He's been battling it for so long, and this chronic infection so bad that he should just have the foot amputated and move on with his life. He didn't like that, so he came to us for a second opinion, and actually a third opinion. He's seen 2 other people who recommended below the knee amputation, and he came to me for a third opinion. As you can see here, like I said, he's got diabetes, hypertension, hyperlipidemia, and chronic osteomyelitis. That was his diagnosis. He came with that diagnosis to the right foot. And osteomyelitis is bone infection. And that's a bad thing to have, especially as a diabetic in the foot. Otherwise, he's got great family support, which is a good thing. A lot of times these folks, they don't take care of themselves very well. And, they may or may not have people around that are helping them. Fortunately for him, he has actually an amazing extended family who, does, a great job of taking care of him. He's like truly the patriarch of the family. And so he's lucky in that extent. And otherwise he feels fine. He actually feels very well. He's a very happy guy, very, optimistic, and has no other complaints. And so when we take a look at the foot from a clinical perspective, he's got good blood supply, right? So a thing that we worry about a lot in lower extremity surgery is how good is the blood flowing down into the lower extremity? Because the blood is like the life force of our body, right? It brings oxygen, nutrients, cellular material to areas to heal, to fight off infections, and all that kind of stuff. And a lot of times diabetics have vascular disease of, well, really the whole body, but especially the lower extremity. And that, limits the amount of blood flow that can get down to the foot and help heal these wounds. Fortunately for him, he has very good blood flow. All right. Because to be quite honest with you, this doesn't look that, for being 2 years, it don't look that bad compared to some other ones that I've seen. And so you can tell right away that he's actually has good healing potential because of that. Otherwise, he feels absolutely nothing, right? So this is a condition where they develop neuropathy, and the nerves of the lower extremity are dysfunctional. And sometimes it causes pins and needles and pain, but sometimes it just causes complete numbness. And that complete numbness is very dangerous because, pain is our body's ability to tell our brain that something is wrong somewhere in our body, right? And if you don't feel something in your foot, you're going to keep doing that over and over again. And that's exactly what happens to these folks. As you'll see in a few slides, he developed a deformity because of that, which then leads to increased pressure in his foot and this wound, right? So we look at the wound. It doesn't look like I said, doesn't look too significant yet, but it does probe down deep to the bone, right? So I can stick a Q-tip or something in there and probe all the way down to the cuboid, which is a bone in the hindfoot. And it's draining a little bit. Not really a lot of acute signs of infection, right? So there's not like a lot of redness, swelling, malodor, that kind of thing. So he doesn't have an acute infection, but he's got a chronic infection that still needs to be addressed in a similar fashion. And again, from a musculoskeletal perspective, he has what's called a rocker bottom foot. It's kind of hard to see on this image, but if you take a look here, so we have a 3D CT scanner at our clinic here at the school. And it gives us a lot of images on the inside, but this is a good picture of his actual foot, of him standing, on the platform. And you can tell the forefoot is not touching the ground whatsoever. It's really all this pressure is just, right overlying the lateral hindfoot and where this cuboid bone sits. And the foot is not designed to be that way. The foot's designed to be more like a tripod where the weight's evenly distributed between the forefoot and the heel. And in his case, almost all of the weight is going right into that cuboid. And so it's just too much for the skin and it causes it to break down. Obviously with chronic wounds and infections, we do some labs and stuff to take a look at, where their blood, where their biochemistry lies, where, their inflammatory markers lie, and where the cellular components lie, and try to determine if they have, a significant infection or not. And he doesn't. I mean, these are kind of mildly elevated white blood cell levels here, but not too bad. And quite honestly, his diabetes, here's his blood sugar over here, is very well controlled. And he doesn't have a lot of, super high inflammatory markers. So that's a good thing, because to me, this is telling me that his body is kind of handling this, but just kind of walling it off, right? It's not totally healing it up, but it's just kind of, sequestering it to the foot so it doesn't get anywhere worse in the body. And so we take a look at his plain film x-ray. And you can see here, this is what we call a rocker bottom foot. So the middle of the foot has gotten totally broken down from what's called Charcot neuroarthropathy. And most of the time it happens right here in the middle of the foot in a diabetic. It can happen in other joints. It can happen out in the toes. It can actually happen in the ankle, and that's a pretty bad thing too. But most of the time it's right here in the middle of the foot. And when that happens, the hind foot tends to plantar flex because the Achilles tendon pulls it up, and then the forefoot goes upwards because of the ground reactive forces, and they get this what we call a rocker bottom foot. It almost looks like a boat shape down here. And you can pretty much tell exactly what you expect it to look like there on the clinical image as well. And so obviously this is a problem, right? We want to get this foot into what's called a braceable plantar grade position. We're probably never going to make it totally normal, right? That's not the goal of this type of surgery. The goal is to get them into a position where we can offload it appropriately, that they can walk around, do their activities of daily living, do the things that they want to do, and not develop a wound anymore. And that's the goal. Okay. So just to, review a little bit about Charcot. So there's a couple of different ways we classify this condition. The Brodsky classification is, the one where it shows anatomically where the location is. And again, his is in the middle of the foot here. So it's, kind of a type 2, kind of type 1, type 2 combined. There's also the Eichenholz classification, or Eichenholz stages. And this is, I think, is probably more important because this shows us the progression of the deformity. And most of the time, this happens from a mild injury that the patient doesn't even know happened. And the body is trying to heal the area, right? It's, sending, blood and cells and things down to the area, trying to heal that area up. It could be a mild sprain. Maybe they dropped something on the foot or rolled their ankle or something like that. Or it could even be from, surgical procedures and that kind of thing. But usually there's some sort of mild inciting event that's kind of subclinical, right? They don't really feel much, so they don't get it looked at. And then they continue to ambulate on the foot, and the increase in blood flow to the area and the increase in micro trauma with repetitive walking on it causes the joints to start washing out. The blood essentially just decalcifies that area and makes that bone very, very brittle and very weak. And then the micro trauma to those areas causes continued fracturing, and it starts to progress over months, right? And so when they first show up, there may be, what we call stage 0 foot. It's just kind of a, maybe warm, swollen, and you don't really see a whole lot. In fact, they probably won't even come in at that point. But it's at the stage 1 where their foot starts flattening out and you might start seeing things, right? The joints are all, we call it kind of a loose bag of bones. They're just very flexible, and the foot's very destabilized, and it's still very warm and red. But it starts to progress. And if you can catch it early, you can get it in a good position where it starts coalescing and starts healing, right? So it will try to heal itself, but it's hard to do. It's hard to get patients at that point. And unfortunately, a lot of times it does get missed. So this is things that, primary care doctors should have an eye out for, and as well as educating patients, as well as their family members, taking a look at the foot. But in this gentleman's case, his Charcot deformity had happened years ago. He just now has a rocker bottom because of it. And so he's all the way into the coalesced remodeling phase, right? So it's all hardened bone. It's not soft at all. It's actually like a fracture that healed in a bad position. And as I mentioned, the mechanism, it does have both a neurovascular and a neurotraumatic etiology. And there's some interesting molecular things that go on as well. In fact, we had Dr. Connors, one of our faculty members here, has done some, good research into the inflammatory cytokines and the molecular biology aspect of Charcot. And that's some very interesting stuff that's kind of, hot topic right now in the profession. But anyway, we get this guy, he's late in the game, right? So he's already had the wound. It's coalesced. His foot's, kind of stuck down in this rocker bottom position. And now he's got chronic infection. And so he showed up with an MRI already. So unfortunately, I didn't even have to order this. What we're seeing here again is this cuboid bone here. And these are telltale MRI signs of chronic bone infection. So we got loss of signal intensity, and that's fairly geographic here. In the T1 weighted image and the T2 weighted image, you got some mild increase in signal intensity. So this is showing us some inflammation going on here. And given the history of the wound and the draining sinus, this is pretty indicative of now a chronic bone infection. So we got to work them up for surgery, right? Again, below the knee amputation is actually a very viable option for these folks. It is a one and done thing. But then they always have to put on a prosthetic leg, right? And then there's some cardiovascular considerations that go along with that. And sometimes, people just don't want to have that done. And in fact, there's been studies that have been done. They've surveyed diabetic patients, and the majority of diabetic patients would rather die than have a below the knee amputation. And so there is a bit of, doing what patients also what they want, right? And so he wants to keep his legs, so he comes to me for a third opinion, and we put together this plan. So first thing, before doing surgery, obviously we're doing all the labs and all that, but we also assess the vascular tree of the lower extremity. There was called non-invasive vascular studies, and so his blood flow is very normal. He does not need to see a vascular surgeon before in order to do any kind of peripheral arterial work. So he's got a full thickness ulceration, osteomyelitis, a cuboid, Charcot, and diabetes with neuropathy. Again, being a diabetic, a big surgery plan, he's got to go through significant medical clearance. And so he did have an abnormal EKG, but, an echo was done, and, his ejection fraction was looking pretty good. He was cleared for surgery from a cardiovascular perspective and a medical perspective. So what's our plan? Step one is to decompress the infection, right? So he still has a wound. He still has an infection in there. Before I go in and start reconstructing stuff, right? And this is just my opinion. There's some debate as to, what to do for these types of things, but I'm not a big fan of using what's called external fixation for these folks. It can be very helpful, and I think that it's useful in some situations, but most people don't want a big external fixator frame on their leg. And I think that if you do a good job of decompressing the infection, you can get away with internal hardware pretty well. And so that's the approach that I take. But the first part of the procedure is actually what's called a modified Link-Witzel procedure. And essentially what I'm going to do is internally amputate the middle of the foot. So I'm keeping the front of the foot because it'll help with balance, a little bit later, but mostly for aesthetic reasons. And then we're cutting out that infection, right? So treating bone infection is kind of like treating tumors, right? So a lot of times surgeons, will take out a, large chunk of a tumor or something like that. And then they'll give chemotherapy to treat the cells that they can't be seen. Same thing with this case, right? So we cut out the bone infection and then supplement it with local antibiotics as well as IV antibiotics in order to eradicate the infection that's there. and perform a primary closure, trying to get this foot totally closed. And this is a very useful procedure. It's been relatively well studied, and it can help to prevent lower extremity amputations. Now, this is a procedure that has actually been described initially in the German literature. So when you find these things, you got to, use your Google Translate skills to figure it out. But basically, it's exactly what it sounds like, right? So I don't have any clinical pictures in the operating room here, but here we are in the operating room. And what I did was make a pretty large elliptical incision, cutting out the wound. So I want to cut that diseased tissue out on the bottom of the foot, get it out of there, and then go in with osteotomes here. And you can see what this is an osteotome. And I'm just going to chisel out all that infected bone in the middle of the foot, implant beads in there that are filled with vancomycin, which is an antibiotic, and they will dissolve as time goes on, and then close this up. And again, get them on IV antibiotics, let this heal. And it may take, a couple months for this to totally heal up. And then, we get labs and everything back in order to see that the infection has been eradicated. And then we can plan a reconstructive surgery to stabilize his hind foot so that he has a braceable foot that he can walk around on. And so, he initially was looking pretty good. And this is the big, whack in the bottom of the foot here. And this is, pretty much what you expect it to look like, a couple of days after surgery. And he's doing pretty well and gets sent at this point now. So he's got a PICC line in, he's getting antibiotics, and you can see here. So, we have to keep him for a couple of days, and obviously, to allow the bacteria to grow, and we can speciate that. And so then, with the help of an infectious disease specialist, we're able to choose antibiotics that are specific to these organisms. Usually they get that for 6 weeks, and it's through a peripheral inserted central line. And so he's going to go to a skilled nursing facility, hang out there for about 6 weeks, get some antibiotics, get some local wound care. They'll take care of him, and then ideally then get discharged and come back to us for surgery later on. Well, about 10 days after the surgery, he started getting shortness of breath, chest pain, and it was very discomforting to him. The doctor at the nursing facility did a standard chest pain panel and workup, and started noticing that his the troponins, they follow these for potentially for cardiac disease and damage to cardiac tissue, right? And in other words, they were looking for signs of a heart attack, coronary vascular disease, and that's what they felt. And they're very concerned about that. So send him to the emergency room, send him back to the hospital, and we see his foot and it's not healing up, right? And that's not good, right? So oh no, it's not healing up. But in the meantime, he's getting worked up because he did end up having what's called an end STEMI. In other words, he had a heart attack after surgery, and that's not something that happens, a lot, but it's not too uncommon to not be ready for it, right? So folks with diabetes have both peripheral vascular issues, but they have central vascular issues too, and coronary vascular issues. And unfortunately for him, he developed, this condition immediately after his primary surgery. And because his heart is not functioning well, remember what I talked about, blood flow to the lower extremity is very important for healing purposes. Well, that's true. And we look at that from a peripheral perspective quite frequently. Usually in his case, right, he had no peripheral issues, but now he's got a central issue. In other words, the blood vessels are fine, but his heart, because he just had a heart attack, is not pumping the blood very well. And so his healing potential has significantly decreased, and now his wound is busted open, and also has a heart attack on top of it. So bad day for this guy, right? So it's not good. And, we got to get him into the hospital and get not only, medicine and cardiology and all that, but most likely a cardiothoracic surgeon. And that's exactly what ends up happening. So they get him in. He's got unstable angina and STEMI. He also has CHF on top of it because, again, his heart's not, functioning very well. And they do the whole workup, and it shows exactly that, right? So an inferior infarct, right bundle branch block, and the cardiologist, stable, has him stable, with sub-Q heparin. They're monitoring it. They do a cardiac cath, right? Because that's what's, going to potentially open up vessels or identify what's going on. Again, he got better with that, but with the local care and the medical care, but troponins kept rising. So again, they did the cardiac cath, and this is just a picture from that, and was determined that they couldn't fix his condition with endovascular maneuvers. So what that means is they need a cardiothoracic surgeon to do a coronary artery bypass graft, right? A cabbage procedure. And fortunately, we have one. We had one at the time anyway at St. Vincent. And ironically enough, him and I so at St. Vincent, we have a multi-specialty group with different types of doctors all in the same office. And him and I in the same office at the same day. And so we see each other a lot and talk a lot and share patients sometimes, but rarely do we have to share patients that need, a bypass graft. And so he had to have that done, and he has, 3-vessel cabbage procedure. And that's good, right? So he did very well with that, and he recovered well from that. But he has this wound now that we're dealing with. And until the heart gets strong enough, and believe it or not, it does actually kind of rebound to some extent, it's going to be limited wound healing. Additionally, he just had a heart attack, right? Which means we can't take him back to the operating room for at least 6 months to do any kind of surgery, whether it's wound care or reconstructive surgery, because the stress of surgery may cause him to have another heart attack and potentially die from it. So we're stuck with just treating him locally at the bedside, and now we're dealing with a weakened heart that so he doesn't have a great healing potential. And also on top of it, he still has a chronic infection that's there. So again, the idea of, well, does the below knee amputation, is that a good idea? Is that a good, procedure for him? Will it rid his infection and he'll be able to move on? Well, maybe, right? We don't know. Yes, it'll rid the infection, but when you have a below the knee amputation, it significantly increases your risk of mortality. In fact, their 5-year mortality rates are very poor. And some of that is because they're, sick to begin with, but some of that is also because now they got one leg that they're balancing on with a prosthetic, and this is an increased strain to their cardiovascular system. So he's got a diseased heart, and now we're going to tell him to work out even harder. And that's a major, red flag for complications down the road. And so that's not what we wanted to go with, and the data does not really support that for his case. So he's stuck with just wound healing in order to avoid the BK. So we're doing a lot of, local things locally here. So local debridements, obviously his wound got a little worse, but we did some wound vac therapy, hyperbaric oxygen therapy, amniotic membrane therapy, and just local care, kind of really doing everything possible to stimulate healing. And again, as his heart got better, his wound got better, and started to totally close in, and ultimately moved on to a totally, near closed foot situation. And over those 6 months, right, he got better and he got cleared for surgery and for the reconstructive surgery, right? And so that's the plan, right? So he got cleared. He wants to do it. He kind of needs to do it. So he needs to do something, right? He either needs to do a below the knee amputation or this in order to offload it. And he planned. He obviously wanted to do limb salvage surgery. And so my surgical plan for that case, so it's still a little teeny wound. Radiographically, everything was clean. His labs were very good. He had no real issues for bony infection. And so I planned a intramedullary nail procedure in order to stabilize his hindfoot. In the meantime, I cut out this little wound here again. When we do that type of procedure, we cut out the distal fibula. So this is a lateral incision here. And we take out the fibula and put it into a bone mill. And what this is kind of like a coffee grinder, but for bone. And you put bone in there, it gives you a bunch of little bone chips that you can use to pack in the fusion mass, and that's what we're looking at here. So what I'm doing is fusing his ankle and hind foot to his distal leg. And then I also, so you can see this here's big intramedullary nail, keeping everything intact. Now his forefoot was still pretty, floppy too. This is maybe one part of the case where I could have done something differently, but I still stand by what was done. And that's that I just percutaneously placed some screws across the middle of the foot. And now could something been put in there, plates and things to make it stronger? Yes. However, that requires another second incision. That's more collateral damage to the foot. And so all I really care about here is trying to get some scarring to take place. It's not really a fusion per se, but some scarring so that the foot just looks relatively straight and we can get him into some sort of braceable device and he'll be able to walk around. And so this is what the foot looks like after the surgery. We give it somewhat of an arch. I do know that that's going to collapse as time goes on. He gets into a walking boot and he still needs to do some physical therapy and stuff like that for gait training. And, we're controlling his edema and all that. At about the 4-month mark, he's walking around in what's called a crow boot, which is it looks like a Eddie Munster type boot, but it's designed for offloading Charcot feet. This is what's called a Charcot restraint orthotic walker. And he's cruising around with a wound-free foot and very happy. Here's the 4-month mark. His plain film x-rays don't look too bad either. It could be a little better, but, with Charcot, anything that's braceable and plantar grade is acceptable. So here you can see, kind of the before and after and what that looks like. Again, he's walking around without any support other than a crow device at this point in time. And there you go, right? So this is the progression of his wound from when it first broke down, then all the way to, closed wound situation and him cruising around the hospital, very happy, and I'm happy about that. Now, the downside is Charcot feet and Charcot issues are very unpredictable. And so about a year or so goes by and he's back to his normal life. He does a lot of driving, does a lot of walking and all that kind of stuff. And, that doesn't always use his crow boot. And he showed back up. He goes, I got a little soft spot in the bottom of my foot and I'm worried about it. I don't want to turn it into a wound like it did before. We take a look at it. And, you do need to follow these patients very closely. And so we take an x-ray and his nail broke. So he has hardware failure. And when these things start to break, they kind of turn into a landslide situation. But this isn't something that we're not expecting, right? Because we know that this type of procedure, this type of surgery in the long-term outcomes are very unpredictable. It's a tough thing to deal with, and not a lot of people really want to deal with it because of its unpredictable nature. But you can't bury your head in the sand, and you just got to be ready for these types of things. And so I'm when I see complications, I jump on them, and that sometimes requires another surgery. Again, fortunately at this point, he's got a healthy heart because the cardiothoracic surgeon did a good job doing a bypass graft. His heart's good to go, so he's got to have a lot of procedures done if he needed to. But before this turns into a problem, I'm going to jump on it in a clean environment because it can get infected, right? If you let it go and the skin breaks down again, it gets secondarily infected. Now you got infected hardware. It's a nightmare. So I elected to obviously take that nail out because it was broke and revise the fusion mass of the hind foot. At this point, actually, to backtrack, I didn't really like that nail to begin with because the company that I use for hardware actually didn't have a nail. So I used another company that don't really like their alloys. And I'm not saying that's the reason why it broke, but this other company that I like, they have very strong stuff and it doesn't ever break. At least it hasn't in my hands. But sometimes that stuff happens and you got to be ready for it. So second time around, I had to make a much bigger incision, revise his TTC fusion. So I make a bigger incision. The reason why I did this was because I wanted to take his fibula, right? So this isn't even a distal fibula, this is the middle of his fibula, out and use that as a bone graft, right? So what I'm doing here is I'm going to take that fibula and I'm going to replace the nail with his fibula, right? I'm going to stick it up to the bottom of his foot. So I take that nail out of there that was in there, put this in there and give him a bony nail that's going to help the fusion mass. And you can see what this looks like here. So this is the nail out. Here's the piece of bone that I cut out in order to stuff into his fusion mass. And that's what that looks like going in. You can see he doesn't have really a wound or anything at this point. So it's nice and clean. We stick that up and there it is, right? And then I'll just put, a lot of titanium on the lateral side of his foot with a lot of screws. And, he does very well with this. Goes on, to a nice braceable foot. Actually, I did take out some screws later on down the road. As you can see here, kind of planed that off a little bit better. But now he's braceable and he is fused at the hind foot, and the forefoot and the midfoot looks pretty ugly, to be honest with you. It's not really ideal, but again, these are just helping scar in the front of the foot to some extent, and now that's what we're looking at, right? So he's got a stable braceable foot. Is kind of again a 2-year ordeal that he had to go through, but that's the name of the game with these things. It is not you have surgery and 6 weeks later you're good to go. This is a long process for these folks, and for the most part for them it's worth it, because having a brace like this and walking around with a brace is a whole lot better than walking around with no prosthetic, no cane. He's got a normal shoe on, doesn't even need a crow boot or anything at this point. And so that makes folks a lot happier, and quite frankly is healthier for them as well, because we know the mortality is very high for these folks when they end up with below the knee amputations. So there he is again. That is it. It's a kind of a long case, but it highlights, I think, a lot of what it is we do. And to be honest with you, I cut a lot of material out of this case. It could have been two or 3 hours long, because there's a lot of wound care and a lot of, a lot of tender love and care with these patients in the office. Let me see if I can stop this from sharing now. There we go. All right. I guess we're still going here. I think.
Yeah.
Okay, good.
That was fascinating. Angela and I were messaging each other while it was going on. It's so crazy to see your patient walk away at the end in normal shoes, just walking down the hallway. It's incredible to see those pictures and then see that result. Well, I want to open it up in case any of our guests want to have any questions for Dr. Ehredt that he might be able to answer, and you can feel free to use your mic, or if you feel more comfortable, you can add them to the chat section. I will make a note that we have recorded this, so anybody who registered today, we will go ahead and send you a link to this. That way you can watch it later as well. Dr. Ehredt, can you see the chat?
What is the longest rapport you can remember having with PT? I'm not sure what you mean by longest rapport. Obviously, we have a good working relationship with physical therapy. I mean, I guess maybe the question is how long, like what's the longest time period that he has to see physical therapy? Probably 8 weeks or so, 8 to 12 weeks of formal physical therapy. But with this kind of thing, they're going to be, always strengthening the leg back up, for a year or two down the road. With foot and ankle surgery, even for simple bunions and stuff like that, it really takes about a total of a year to get 100% better. And that's because people deal with a little bit of swelling and stiffness and things of that nature. It's just the way it is. With this, especially with the Charcot recon, that's, kind of slower to heal and everything, it could be 2 years, until they're good to go. And just like in his case, right? So the first one, we did the IM nail, looked good. He goes about his business. comes back, 6 months to a year later, and not not looking good, right? Because the hardware broke down. It's at least 2 years until that you've done well. So we follow these people pretty closely, even when they're totally healed up. He'll come in to see me like probably on an every 3 to 6 month basis. Again, fortunately for him, he actually has a very good family support, so they're always checking on him and making sure he's a-okay. But for some folks, they don't, and so you may need to keep them a little closer to make sure nothing funny is going on.
You had mentioned that earlier, Dr. Ehredt, about the family and how they provide a lot of
Yeah.
support. How important is that to you moving forward when you treat a patient, knowing the support that they have in their family or home?
So it's very important, right? If anybody's ever been on crutches, or if you haven't been on crutches, I challenge you to just go and get some crutches and try it out, right? I know they said don't do that because it's bad luck, but it's not easy, right? I know I had I had knee surgery when I was in college. I had to get around class on crutches and carry my bag, and I was a young, strong guy, and it was pretty difficult. Now, if you add on, maybe you're a little older, overweight, you got medical problems, you got to take the bus, you have nobody to help you put your clothes on or whatever, it becomes really, really difficult. And so that's something I always want to know, no matter what the surgery is, because that might mean that doesn't mean you can't have surgery. It might mean that, right? It might just come down to, well, doing this may unravel your life, right? Um, or it may mean that you just need to go into like a skilled nursing facility or something like that. Um, Additionally, I also like to know what people do for a living, right? So, everybody makes money somehow. And if you work behind a desk, maybe you can go back to work on Monday. If you work on a factory floor somewhere, or you're in landscaping or whatever, you're a police officer, or who knows what, it's going to be a bit different. And, patients need to know that, you can't, just paint a rosy picture where, you're going to be back to work in a week or so, because it may not necessarily be that way. So you just have to have a good idea of their social support and what they do for a living. Some people are fortunate. I mean, maybe they have a pretty tough job, but they have enough time saved up to take off or whatever. You just got to work it out with them. I see another. Yeah, so I do. Everybody's this way, right? So what we do is very similar to carpentry, and to a certain extent. And if you talk to carpenters, there's certain things that work well in their hands compared to other things. Doesn't mean that different products are actually better than the others or whatever. But you get better results when you get comfortable with certain companies. And there are a handful of companies that do a very, very good job of that, especially the lower extremity. There's very specific procedures that we do, and so we need some very specific instruments, some very specific implants. And I would say that it probably took me about 5 years to totally hone in on what it is that you like to do. Because when you first start out, especially as a resident, you're learning under somebody else, and they're not just gonna, usually they're not gonna let you just run away with whatever it is you want to do. They're gonna do things their way, and you're gonna learn it that way. And so as you're a resident, you're kind of taking a little bit from everybody you work under and making it into your own, algorithm in your head. Then when you first start working, now it's up to you. And so you take those things and you start doing them. Sometimes you learn, through, the school of hard knocks, that it doesn't work as well as you thought it did, and you alter things up a little bit. And it takes a couple of years to really get that way, but you got to be very critical of your own work. And I think, that's kind of the board review process is that way, to help with that. But I'd say it take about 5 years to totally get zoned in. Have you ever had patients try to abuse their time off from work or pain management drugs? Yeah, of course, right? Unfortunately, there's a major narcotic pain abuse problem in the country, and I'm not going to get into the details of who's at fault and all that kind of stuff. It just is what it is. And so I actually have a very hardline approach to that. In the state of Ohio, which is where we are here, there's laws against what you can and can't prescribe and for how long. and for what you've done. I tell them that during their preoperative consultation, say, hey, this is bone surgery. It is going to hurt. It warrants narcotic pain medicine for about a week. To be honest with you, it probably warrants it for about 3 days, but everybody's pain is a little different. So, 3 to 7 days, I think, is reasonable. After that, it's ibuprofen and Tylenol. And the evidence is very clear that the combination of ibuprofen and Tylenol is equivocal to pain control as Percocet for orthopedic type pain. So I'll show them the papers, and I'll show them, hey, this is the way it is. Do I lose a couple of patients who are doctor shopping and they're there for, dubious reasons? Yes, but I don't care because, I know that I'm doing the right thing. Because that's how I deal with that. Now, there are sometimes people who have legitimate pain management problems, and maybe they've been on opioids and things like that for a long period of time before they've seen me. Not going to deal with that. I mean, I'm not going to manage that. We have addiction medicine specialists for that. We have pain management specialists for that. So get them set up with those folks. But you have to just have a hard line. You have to draw a line in the sand and say, look, this is the way it is. I'm not giving you narcotics after, a certain time period. And then time off, that's a whole nother story. When people get injured at work, they tend to not recover as well as people who don't. I mean, there's a lot of studies on that. And are they lying? Maybe. So you just have to be very objective in your findings. But also know that sometimes people have chronic pain, and if that's the case, for example, if I do surgery, everything looks great clinically, they're strong, everything's healed up, x-rays look great, and they just say they're in chronic pain, I'll do some investigation to find some other reason or some nerve etiology pain or whatever, but then ultimately send them to pain management if that's the case, because they could just be kind of bluffing. Anyway, in the case of Charcot neuroarthropathy, blood flow is important, but in a patient with poor blood flow, would they be less likely to develop Charcot? Yes, actually. They are a little less likely to develop Charcot. But to your second point here is, yes, the prognosis is much poorer after surgery. So if somebody shows up, they had a Charcot foot at some point, and now they have a wound, but they also have peripheral arterial disease, if it's infected, okay, do your surgery to decompress the infection, because that always kind of takes precedence. But really, you should optimize the blood flow to the lower extremity before you do any kind of, reconstructive, heroic surgery, because it might not heal, and you might have just caused them a bigger problem because of that. So yeah, you got to work that up. Do you, in cases where your proposed plan of treatment is the patient's last resort, but the patient may refuse that treatment? All right. What do you do in case where does the patient refusal conflict with do no harm? No. So if doing nothing would result in loss of belief for results. So obviously patients have the autonomy to do what they want with themselves. Right now, if they have psychiatric condition and they don't have the ability to make their best decisions, then you can get, some sort of, power of attorney or whatever, I'm not going to make that decision, right? If I assess someone and I say, okay, Mr. Jones, you got an infection in your foot, and if I don't do surgery on it, it might go into your leg and cause you to die. And he says, no, I don't want that. I'd rather die. Probably you'll put in a psych consult and say, check this guy out and make sure everything's okay. Now, if they say there's nothing wrong with him, he can make his own decisions. If I just go and do surgery on him without his consent, that's battery, right? I just, touched him without his consent. People sometimes do, and sometimes they leave. 9 times out of 10, they come back. But patients have their own autonomy to do what they wish to do. A lot of times we see this not so much in like a loss of life or limb situation, but in the elective surgical world, where there's a couple different ways to fix a problem. For example, in the first MTP joint, right, the big toe joint, people get arthritis. They make little joint replacements for those, okay? But I'm telling you that they don't work that well, right? Now, some people would say that they do, but the literature is pretty clear. They have about a 5-year shelf life. And after that, we don't know what's going to happen to it. So the alternative is to just fuse that joint together. And most of the time, that's what I do, because I know that if it fuses well, they'll have long-term pain relief and they'll ambulate very well on it and all that. But I talk to patients about the differences in the types of surgery. And, you know, I may think that fusion is best for them based off of what the data tells me, but they might just really want to do a replacement because they just want a little bit of motion, or maybe their job requires it, or they want to do yoga or whatever it is they want to do. As long as they know that I can't guarantee what that implant is going to do 5 years down the road, and that it may require another surgery that's even more complicated to revise the implant, take it out, and maybe even do a fusion. They're educated on it. I've educated them. They've made it an informed decision. Maybe it wasn't what the best thing to do up front, but they have the autonomy to do that. So those are my thoughts on that kind of thing. Eventually the nails be removed. Oh, so screws and things that you put in someone that are hardware related, most of the time you want them to stand there forever. I got screws in my knee. They're still there. They're fine. They don't hurt me or do any problem. Sometimes they do, though. Sometimes, screws or plates can cause a little bit of pain or irritation. Even sometimes people have metal allergies and stuff that can develop. Very rare. But once the bone is healed up, you can do what's called a hardware removal, and usually tends to resolve the problem. But I would say 9 times out of 10, it's just there for their lifetime. So I peeked at some of the publications that were listed in Kent State profile. I was interested by the case he implemented a pediatric flexible IM nail for percutaneous reduction of fibula fracture. I'm interested to know if it was the case that there weren't any other previously used IM hardware for this type of fracture, or if there's a specific purpose. Okay, so in that particular case, and I've done that on a number of cases, actually. As a matter of fact, I published another one in, there's a new journal called the Fast Track, Foot and Ankle Surgery Techniques and Cases, or something like that. And that's an off-label use. Okay, so a pediatric flexible nail, or really an elastic nail, is used for femoral fractures in pediatric patients. So you percutaneously place it, and it comes with this little T-handle, and you can, reduce fractures in a percutaneous fashion, which is good because that minimizes the soft tissue damage, right? So anytime you cut on things, it's got to heal, right? And so if you make a big long cut to put plates and screws and stuff like that in, it's going to increase the healing process, increase complications and all that. So the goal, has always been to move towards endosteal forms of fixation and percutaneous fixations and things of that nature to help minimize the collateral damage that is done. And when it's appropriate, nailing procedures can be very good. And so in those types of cases, so that particular case was a patient who had sustained an ankle fracture, was unstable, but they also had, some comorbidities and some peripheral arterial disease and all that. If we made a big cut on it, right, which would have been ideal, right? So when you fix ankle fractures, usually you put plates and screws in there, and that's stronger. Right? It definitely is. But that big incision right over where hardware is going to be might not heal. And then if it doesn't heal and it gets infected, now you got a bigger problem than you dealt with, that you started with. And so in that case, using those percutaneous type of devices are mostly to try and prevent either more problems down the road. And some specialist physicians have described lengthy charting. Would you say charting as DPM is as lengthy as other intricate specialties? I think it is. As you guys know, our profession is an evolving profession. And I think as we have evolved, out from the old days into mainstream medicine, we've had to kind of, beat our chest a little bit. And so I do think some things we do are a little over the top in order to show our competence, honestly. But that's fine. Also, though, too, we do work in a kind of an intricate part of the body, right? And, the foot's got 26 bones, 28, including the sesamoids, a bunch of little joints and ligaments. And it's, this kind of interesting moving machine. And so there are a lot of moving parts that you have to talk about. So I think it's about the same. But unfortunately, it's just the way it is in medicine, right? That's the bane of every physician's existence. You hate to have to chart, but obviously you have to do it for, the documentation purposes, your continuity of care purposes, medical legal purposes, and billing purposes.
These were some great questions. I think what we're going to have to do is wrap up in a moment. So if there's any other questions for Dr. Ehredt, or he did provide his email on the presentation, and we can go ahead and get that presentation out to everyone after, just in case you have a question that Dr. Ehredt can ask or answer later on. But I want to thank you all so much for coming, and especially thank you, Dr. Ehredt, for your time and for sharing that wonderful case study with all of us. What we'll go ahead and do is send out this presentation a little bit later this afternoon. But again, thank you all for joining us, and thank you so much, Dr. Ehredt. Have a great afternoon, everybody.
All right, thank you.